Good evening, everyone. On behalf of Raven L. Hill, president of Alpha Kappa Alpha Sorority Incorporated, Xi Omega chapter, and our over 670 plus members, I bring you greetings. My name is Nicole Jackson Williams, and I serve as the first vice president of Xi Omega chapter. And I'm so happy that you are sharing some of your evening here with us tonight. At this webinar, our panelists will talk to you straight from the heart about cardiovascular disease and how it impacts African American women. Did you know that women of African descent have a 50% greater risk of developing cardiovascular disease than any other racial group? These same women also have a higher rate of obesity and diabetes, which places this population at a higher risk for heart disease. Tonight, you will hear from our panelists who are experts in the field. They will be able to break this information down even further for you. So now I would like to introduce the first of our three panelists to you. She is a Xi Omega member, and her name is Ms. Katrina Richardson. She is a certified nurse midwife and women's health nurse practitioner who has been serving women in the Maryland area for the past 7 years. She is a native of Wisconsin and graduated from Tennessee State University and the University of Wisconsin-Milwaukee, where she earned degrees in biology, chemistry, and nursing, respectively. Seeking to enhance her partnership with women, she attended George Washington University, where she completed her Master's of Nursing with a concentration in midwifery and women's health. She emerged as a health provider ready to facilitate the standards of midwifery practice and promote the standards of quality in women's health care. So I'm now going to turn it over to Ms. Katrina Richardson.
Thank you, Nicole. Now I'm going to be introducing our next panelist, Ms. Andrea Anderson, MD. Dr. Anderson is a family practice medicine doctor and the chair of the DC Board of Medicine. She is the Associate Chief of Family Medicine at George Washington School of Medicine and Health Sciences. She co-directs the Health Policy Scholarly Concentration and is the course director for the Transitions to Residency 4th Year Required Internship Readiness Capstone course. In 2019, she was appointed to the National Board of Directors of the American Board of Family Medicine and is the first African-American woman to be appointed to this role in the organization's 50-year history. In 2021, she was elected to the National Board of Directors for the Federation of State Medical Boards and federally appointed to the National Advisory Council of the National Health Service Corps. Through her career, Dr. Anderson has been active in the DC health policy and medical regulation, as well as teaching ethics, professionalism, and physician advocacy to medical students and residents. This year, she is an appointee to the DC Health Scientific Advisory Committee advising ethical and equitable COVID-19 vaccination distribution. She serves on the management committee of the USMLE and other national committees of the National Board of Medical Examiners. She sits on the FSMB National Ethics and Professionalism Committee and the Health Equity Task Force and the National Academic Family Medicine Advocacy Council and Committee. She serves on the Executive Committee of the Transitions to Residency Educators and the STEM National Underrepresented Minority Faculty Development and Retention Task Force. Previously, Dr. Anderson spent 15 years in practice at the Unity Healthcare, a large federally qualified health center network in Washington, D.C., where she served in various leadership roles, including medical director of family medicine. Dr. Anderson has testified widely before various outlets, including the 2019 testimony before the Senate Health Committee to increase congressional funding for the National Health Service Corps. She has also been honored with various awards, including the 2019 National Advocate Award for the Society of Teachers of Family Medicine, the 2021 AAFP Exemplary Teaching Award, and the 2021 Leonard Toe Humanitarian in Medicine Award for the Arnold P. Gold Foundation, the National Medical Honor Society, highlighting faculty, residents, and students who exemplify the compassionate patient care and serve as role models, mentors, and leaders to medicine. Thank you for joining us.
Thank you. Thank you for having me.
And so I will now introduce our third panelist, and that is Dr. Finley. Dr. Clarence Finley grew up in Prince George's County, Maryland, and is the son of Caribbean immigrants. Dr. Finley earned degrees in molecular biology from Princeton University and MD and PhD degrees at Duke University. He completed his internal medicine residency at Massachusetts General Hospital in Boston. He then continued his training at Stanford University in California and served as General Cardiology Fellow and Chief Fellow. He is board certified in internal medicine, cardiovascular disease, and interventional cardiology. He completed a subspecialty fellowship in interventional cardiology at St. Luke's Mid-America Heart Institute in Kansas City, Missouri. He practiced as an attending physician in interventional cardiology in St. Joseph, Missouri, at Mosaic Life Center for 3.5 years, and decided to go back to school for an executive MBA and continued medical training in structural heart disease. He recently completed his structural heart disease fellowship at the Heart Hospital at Baylor in Plano, Texas, and has now joined Capital Cardiology Associates to help enhance the quality and breadth of care provided here in Prince George's County. He enjoys working out, professional soccer, traveling extensively. He has visited over 45 countries, spending time with his wife and his 3 daughters. He is committed to compassionate, empathetic, evidence-based, and quality medical care. So I now bring you Dr. Finley. So I'm going to go ahead and kick off the first of our questions. And the very first question that I'm actually going to pose to all 3 of you, and we will let the ladies go first. So we'll let Dr. Anderson go first. That question: why are African Americans at greater risk for heart disease?
Thank you for that question. And the answer is a complex one. You know, as you mentioned, heart disease is the leading cause of death for women. And many women don't really even realize their risk. Heart disease is the leading cause of death for African American women. And more than half of African American women will have some form of heart disease as they age. Things that can predispose African American women to heart disease are things that we suffer from as a community, things like obesity, high blood pressure, things like diabetes, and high stress. But you also have to look at structural factors that our communities face that also predispose us to these levels of stress, things like inequity, inadequate housing, economic disparities, microaggressions, and racism that are the result of racist policies that can also cause these type of predispositions. So you may think, oh, it's just a genetic predisposition, but in many ways, social factors predispose us to high levels of heart disease as well.
Thank you, Dr. Anderson. Ms. Richardson, would you like to weigh in on that from your perspective?
Sure. So in addition to all of that, again, my specialty is in pregnancy, and a lot of times we don't know what brings about hypertension in pregnancy, but they think that, and the research has started to realize there may be some part of implantation that may be causing some of the hypertension in pregnancy. The research is still out there, but that is one major factor that they're working on right now.
Okay, thank you. So I'm going to go into the second question, and whoever would like to go at it first, I'm going to just say unmute yourself. And so this question is kind of geared towards congestive heart failure, and we hear about this so often. And so the question that I'd like to pose is, how is congestive heart failure different from a heart attack or how is it different from cardiac arrest?
If you guys are okay, I'm happy to jump in on this one. I got my technical issues sorted out. I apologize. So there's sort of three different buckets. The first I'll address is a heart attack, and a heart attack is effectively a reduction in blood supply to a portion of the heart, and that generally comes when there's a blockage in the heart, either from increased calcium or cholesterol deposits, or sometimes even a clot within the heart arteries that prevents blood from going from one area to the next. The area that's not receiving the blood then begins to become irritated, and you actually have cells that die off, and that is sort of the classic description of a heart attack. When you think about cardiac arrest, that's a scenario where the cells that become irritated because they're not receiving blood supply, there's a level of activity that increases, and sometimes they'll develop an electrical pattern that is oftentimes not consistent with or does not necessarily lead to enough blood flow leaving the heart. So you'll find that you can be at the grocery store and you'll see somebody passed out, and that's because their heart developed an abnormal heart rhythm that prevented enough blood from leaving the heart to get blood to the brain and the rest of the organs, and then they pass out. And so it's our job at that point in time to try to restore a normal heart rhythm so that they can get blood flow to where they need to go. And that's the reason for needing to know CPR, as well as being in a place where you have these devices like things called AEDs, or automatic external defibrillators, to help put people back in a normal rhythm. And the last thing I'll touch on is the congestive heart failure, and that can happen for a variety of reasons, but suffice it to say, either the heart is too weak to pump blood out of the heart to be able to get blood to the brain and the rest of the body, or enough blood, or the heart is too stiff and it's unable to relax and receive the blood to then pump the blood out of the heart. And there are a variety of reasons why someone can develop heart failure, but that's really sort of the general picture. It's basically a weak heart or a stiff heart that can't receive enough blood. So those are the three categories.
Thank you, Dr. Finley. And Dr. Anderson, I'd like to see if you can expound on that. Can you give us some risk factors for the both of those conditions?
Yes, definitely. And I really appreciate how Dr. Finley broke that down into those three buckets, because heart disease is really a continuum of conditions or diseases, right? So the risk factors that are very common, as we mentioned earlier, things like high cholesterol, high blood pressure, stress, lack of adequate sleep we are finding out is a really big contributor to heart disease. And that's something that women specifically are so busy and taking care of everybody else, myself guilty included. And, we can really eat into our sleep and our rest, which we know can be a factor in increasing blood pressure, increasing stress, and increasing weight. Things like a sedentary lifestyle, not making enough time for aerobic exercise, high salt diets, high fat diets. So all of these risk factors can work together over a long period of years, even from your 20s and your 30s, and then become manifest as we start to age into our 50s, our 60s. And that's when you start seeing people suffer from the risk factors of high blood pressure, et cetera, and then ultimately the heart disease that comes from those risk factors.
Thank you so much, Dr. Anderson. And what I'd like to do is this is Women's Health Week. And so I'd like to look at, in women, what are some key things that you all may notice in women. And I'm actually going to just kind of work around. I want to include our nurse midwife in. So just thinking about that, how would you focus it in on the patients that you treat? And then I'm just going to ask each of you to talk about the patients that you treat and those same risk factors. Ms. Richardson, I'll start with you.
Sure. So I, in the office, see a lot of women who have a lot of going on in their life. They have children, they have their jobs, they have organizations that they're a part of, and all of that eats into their time, increasing stress levels and increasing and getting their anxiety up, And it really is a time in which you have lots of stress in your life when you have all these things going in, right? So it's really important to say, hey, you're here seeing me. Let's talk about ways to mitigate and ways to try to at least deal with the stress, or organize your way and organize your life in a way that will decrease the stress and make time for yourself. Whether or not that's just taking 5 or 10 minutes to, walk to the get your mail, or stopping after work and really taking time to say, I'm going to just kind of clear my head. Let me go have a nice you know drink, like something from like a tropical smoothie. Creating time with yourself, and putting boundaries around the time that you spend with others, so that you can really concentrate on looking into yourself and creating that time.
And Dr. Anderson, how would you add to that? What advice do you give your patients in terms of minimizing the hypertension and those sorts of risks?
Definitely. So often, as was mentioned, patients and specifically women can put themselves last on the list. So we're taking care of our, like you said, our organizations, our children, our spouses, our communities, causes that we're passionate about, and we can make ourselves be last. One thing that I often see with my patients is that they ignore symptoms of heart disease. They can ignore symptoms of heart disease, ignoring things that have been going on for a long time. For example, chest pain. They can explain it away as indigestion, as gas, as back pain, as fatigue, a little shortness of breath, and not realizing that these are symptoms of maybe an active heart attack or symptoms of worsening heart disease. Ignoring things like getting your blood pressure medicines refilled. I can't tell you how many times my patients say, oh, I ran out last week and I meant to get the refill, but what happened was, all the stories that we all tell ourselves, or I was rushing, that's why my pressure's up, or I was arguing with my son, that's why my pressure's up, right? It doesn't matter why it's up, right? If your house was on fire and the firemen come and you say, oh, well, it's a gas fire, they're not going to be like, oh, okay, it was just that, let's not put it out. I mean, it's still a fire, right? It's still something bad that's going on, right? So regardless of the reason your blood pressure is elevated, it's still elevated, and it's still causing damage to your heart and damage to your blood vessels that could lead to heart disease. So that's the one thing I really see a lot, is that we ignore symptoms over a long period of time. And then when they really manifest is when, often it's sometimes too late to really make a difference, unfortunately.
Thank you so much. And Dr. Anderson, expanding upon that, in terms of when a patient gets to you, what are some of the things that you see? How do you even treat those sorts of issues that come as a result of the hypertension and the other risk factors?
You said Dr. Anderson or Dr. Finley? I'm
Oh,
sorry.
I'm sorry, Dr. Finley.
Okay, all right, no worries. I was like, let me be quiet.
I mean, I
All
can
right.
I'm sorry.
So I wanted to do a couple of things. One is expound on what Dr. Anderson was saying, because I think that's actually a very important point. A lot of the classic studies that were done on how patients present with chest pain were done in white males, okay? And this is a lot of the data that has been derived from back in the 60s and 70s. And so I tell a lot of my female patients that they need to understand that they may actually present differently. So some of the symptoms that Dr. Anderson sort of noted, specifically the indigestion, that's actually a sign to me. Whenever a patient tells me they have a lot of indigestion, they're taking the Tums, it may or may not get better, or after I eat, I have some symptoms that seems to sort of improve, several hours after I eat. Those are actually signs that something may be going on, and it's just that females present differently. And then I don't say chest pain, I say chest discomfort, anything that should not be in your chest that you're experiencing, so that patients can say, well, maybe I have some pressure, heaviness. It gives them the opportunity to describe a little bit more about what may be going on and things that we would ordinarily miss. The other things to mention, in addition to the indigestion and sort of sometimes patterns with meals, is jaw discomfort. So patients will tell me I have pain, but it's when I exercise, it's just discomfort in my jaw, and that's it, nothing else. Or in my neck into my jaw. that's a sign that something may be different. And in fact, I've had several females present that way when they were having active heart attacks. No chest discomfort whatsoever, just present in the neck or jaw. And so those are sort of the different symptom patterns that I do see with my female patients that I make sure that they're aware of and they pay attention to and they don't neglect, so that we can get them where they need to be treated appropriately.
Can I just jump on that? And I just wanted to add, if it's okay, Madam Moderator, that, you know, even doctors are taught how to recognize heart attacks in men. We're taught about, you know, the classic, like, there's an elephant sitting on my chest, you know, this like horrible chest pressure, even in classic TV, right? Like Sanford and Son, right? He like clutches his chest. He's like, I'm coming home. You know, it's like this big dramatic thing. And many times in women, it's very subtle, right? It's like I had one patient tell me one time, it was like something was in my chest. Like I was trying to burp it out. I was trying to just get it out. Like it wouldn't come out. You know, that's a sign of a heart attack. They'll say things like, I was so uncomfortable, or I had, you know, palpitations that were worsening, you know, this kind of like fluttering that kept getting worse, things like that. You know, always take account of those kind of symptoms, because they can be subtle hints, subtle whisperings that, hey, something's wrong, something's going on. You need to let someone know about it.
Thank you so much, both Dr. Finley and Dr. Anderson. Thank you. So I'd like to shift it just a bit, because we're still kind of talking a little bit about hypertension. And for Ms. Richardson, I'd like to know, how does hypertension affect pregnancy?
Sure. So when you're talking about what hypertension does, like we were mentioning before, it really just affects the arteries, right? So it affects these arteries by making them less elastic and less pliable. So then at that rate, you have less nourishment going to the mom and throughout her body, i.e. the placenta in pregnancy. So with a decrease in the amount of oxygen carrying capacity and the decrease in the amount of nutrients that are carrying throughout the body to the placenta and i.e. to the baby, that can affect the pregnancy in so many ways. So what happens with the babies is there can be developmental abnormalities. There can be growth restriction. There could be issues with low birth weight. Also, as we're mitigating the disease process in pregnancy, it may have implications of delivering a baby preterm. So if we're, having to mitigate the worsening of the disease, that's increasing the risk of preterm deliveries, right? So that's just the baby part of it. But when you're talking about, the mother too, that can affect her heart, her kidneys, her lungs, her liver, and all of that is just the physiology part of it. So you have all these physiopathological things that are happening with the body, but then also we're talking about how are we going to manage this labor? So it's going to affect pregnancy from the standpoint of you're going to probably be taking more blood pressures at home on your own and maybe reporting them to your provider. You are probably going to be, or you will be getting more ultrasounds and surveillance done. You're going to be getting more labs drawn. You probably will be seeing a maternal fetal medicine physician. And you'll more than likely, depending on how severe it is, maybe even being on medication as well. So it's a myriad of different things and how it affects the pregnancy. And again, with the stress and having family and all of that, that increases. And there's some people that have anxiety just about having hypertension in pregnancy. So it can compound as well.
I have to be honest with you, I was nodding because I was that patient. First pregnancy is when it was discovered, and the second pregnancy, they treated it right away and put me on a medication. It was a different medication because of that. So what I would like to shift and ask both Dr. Anderson and Dr. Finley is, do you see the hypertension go away after pregnancy?
I would say sometimes, if you've had hypertension in pregnancy, it does put you at higher risk of hypertension post-pregnancy. So many times, you have to be careful, especially during that initial time right after birth where you might be transitioning from your OB back over to your primary care doctor or your family physician. Many people are like, oh, great, baby's out, I could stop taking this medicine. But that's really when you're going to declare yourself as either just a preeclampsia or hypertension of pregnancy, or are you an actual hypertensive? Is this something that's gonna not go away? And so again, those same lifestyle, environmental factors that put you at risk for hypertension in pregnancy are generally still there. And now your life's more stressful because you have a baby. And sometimes you have more than one kid, right? So it's not like your stress decreased necessarily. And so sometimes you're going to have more risk factors and more reasons to stay on top of your health, and not just focus everything onto the cute baby that you've been given, but still take care of yourself as the baby's mom. So, and I think many times there's a denial or a reluctance to admit that you have high blood pressure or admit that you need a medication. I have a lot of patients who are like, oh, I don't like medications, I like to be natural, like I don't want to, I don't get involved in that. I can just bring down my pressure by, meditation or something. And I no, yeah, totally meditate. I'm all for it. But if you're still having those increased readings, you might need something additional. That's why it's called, integrative practices. Like you can do them both at the same time. It doesn't have to be, one or the other. And, keeping your blood pressure at bay while you're working on the stressful job that, you need to leave, or while you're working on, decluttering your life and bringing that stress down, that medicine can help keep that blood pressure stable while you're working on those lifestyle factors too.
Thank you. And Dr. Finally, is there anything you'd like to add in terms
I don't have
of?
much to add to Dr. Anderson's point, other than if you're still noticing that your blood pressures are elevated 6 to 12 weeks out post-pregnancy, that's a sign that you need to implement lifestyle, diet modification, just like we discussed. And if things don't turn around, then I think moving towards consideration of starting a medication is where we need to be. But otherwise, just to give you a time frame for what we need to be looking at, 6 to 12 weeks.
Okay.
And I would just like to add as well, we do see moms for, that first, 6-week appointment. So we're still managing that hypertension in pregnancy, even though you've delivered. The time in which the immediate postpartum time is the time in which it's most likely to rear its ugly head. As you get further out, you can kind of get a little bit more in the safe zone, but you're still not out of that safe zone for us OB wise until that 6th week. And if we're still seeing those blood pressures and things are still staying steady, where you're still having hypertension, you're still having symptoms of hypertension, then we are sending you over to our lovely family practice people.
Thank you. And I'm just curious, is there a difference between hypertension and preeclampsia?
So we categorize hypertension in pregnancy different ways. So starting with, with a different symptom. So we diagnose it several different ways. We diagnose it with blood pressure, with symptoms, and with labs. So we categorize, number one, is somebody coming to pregnancy with hypertension already occurring. So that would be someone who has chronic hypertension, whether or not they're on medications or not on medications. Then we have the category of gestational hypertension. Gestational hypertension is usually someone who has presented to pregnancy having normal blood pressures, and then somewhere around 20 weeks, they start developing blood pressures somewhere in the ranges of like 140s over 90s. Then the next category is preeclampsia. Preeclampsia is when you start to develop organ damage. So your kidneys and your livers are showing signs in your lab work that things are changing. And then there's 2 subsets of that where you can have either severe hypertension or hypertension without severe features. And that's when blood pressures can get a little bit higher into the like 160s over 100s range. You're seeing changes in the labs. So that's indicating to us that it's getting a little bit more, intense as far as the progression of the disease. After preeclampsia, you can then develop, which is preeclampsia with the development of seizures would be eclampsia. And then after that would be HELP, which is more like a product of hypertension in pregnancy, but that's when you're kind of having more of a degradation or a demise of the liver and your clotting factors. Is rare, but we do see it. So those are just kind of the progressions of what we're seeing hypertension do to the body and the vessels in pregnancy. So there's different ways that we use those blood pressures, i.e. are they, normal range? Are they getting to that 140s over 90s? Are they getting to more of a severe range? Are we seeing changes in your labs with your, the way that your kidneys are functioning, the way that your liver is producing its products, and then also symptoms. So symptoms being, are you having headaches all the time? Are you having visual changes? Are you having abdominal pain? Are you having swelling? So we use those to categorize and diagnose the different types of hypertension in pregnancy.
Okay, thank you so much. I would like to pose this question to Dr. Finley, and I have one here, and it states that although African-American adults are 40% more likely to have high blood pressure, they are less likely than non-Hispanic whites to have their blood pressure under control. In your opinion, what are the barriers to achieving and maintaining healthy blood pressure ranges in the African-American community?
That's an excellent question. I think obviously several issues, and one of which we pointed out already, but there's this reluctance to accept the fact that it is high blood pressure and they may need to take a medication to treat it, to get it down. And I think that's the biggest hurdle to get over. But even before that, what I try to do is the diet and lifestyle modifications that you empower patients to then, try to do things on their own to get themselves where they need to be. And oftentimes that fails, right? So we can lay things out. There's certain books that I even recommend. I'll tell them exactly where to go get it. I'll write everything down, and then I'll see them back in a month and nothing has changed, right? So it's not really adhering to a good diet and lifestyle modification regimen. It's also the reluctance to accept the fact that it is high blood pressure, and then the desire to even start the medication to begin with. And so trying to work on all three of those issues, I think, is really what is going to help to move the needle. And some of that, to be honest with you, comes from a lack of trust of the healthcare system, right? So if you are standing across from someone who looks like you and says, listen, that medication, I treat multiple patients with it, it works. This is a place that we absolutely need to go. We need to be doing these things to ensure that you can, enjoy a good quality of life. I'm not talking about 10 years from now, but 30 and 40 years from now. And if they can look at you and sometimes see themselves in you, and sometimes recognize the fact that you're not just pill pushing, but you actually care about how they turn out, sometimes that is what is required to help move the needle. And so that's something that, we kind of really don't talk about it. But if I trust my provider, I'm more likely willing to do some things that they recommend first rather than not. So it's working through those things and being very upfront and honest with your patients, trying to establish that direct line of communication. And I tell them, I said, listen, if you don't want to take it, you don't have to take it. Let's just discuss why, so we can figure out which path we need to go next to get you where you need to be. So those are the things that I would highlight as potential roadblocks and things that we need to get over to get to move the needle in terms of bringing down some of those numbers.
Thank you, Dr. Finley. And Dr. Anderson, is there anything you'd like to add?
Yeah, I would add that, I appreciate how Ms. Richardson went through the signs of hypertension in pregnancy. And many times hypertension in non-pregnant people is what we call silent, right? It's the silent killer. So that's why people say, well, I feel fine, I don't need to take my medicine. Or I have my patients say, well, I only take it when I feel like it's up, right? But if you are feeling it up, that means it's like really, really up, and it's been up for a while that you didn't take it and you should have. So I think that that's a really, another key thing is that you can't feel the symptoms. It doesn't always hurt until it's bad. And so really convincing people that this is something that you need to maintain every day, all the time, take your medicine regularly, regardless of how you feel. That's really something that needs to be driven home. I appreciate that fact that Dr. Finley said about having, race concordant providers, right? A provider that looks like you. the data is actually very high, especially for African-American men, that if they have an African-American male physician, that they're more likely to be compliant with medications, and they're more likely to have, regular screenings done, lowered blood pressures, a lot of things, right? Because it's that trust factor. Unfortunately, less than 5% of physicians are African-American. It's a very small number. And so something like 2% Black women, 2% Black men, somewhere in there. So unfortunately, that's another thing that we need to fight for, is getting more African-American providers into midwifery, into medicine, so that we can have some more of that representation that was mentioned, because it's very important.
Thank you. And just to build upon that, so do you think that probably what you said, and maybe you can expound on this, why do you think there is a steady increase in the rate of heart disease in our community, despite all of our advanced knowledge and medical technology?
I can jump in. So I'll clarify one point, and that is, if you look at the trends over the, let's say, past 10 years, the numbers actually coming down, okay? In terms of, if you look specifically at Blacks, right? Less of us are dying from it, or developing heart disease, et cetera. However, when you look at us compared to everybody else, we're significantly higher, right? And that's really the difference to highlight. And I think a lot of it really dovetails into the diabetes, the obesity, the lifestyle issues, that we've been talking about, the stress that we take on, right? If you're sitting there worried about how you're going to pay your next bill, that, those things take its toll over time, right? That's not a concern that you have once a month. It's a concern that you're thinking about every day as you're going to work. And over time, that stress starts to take its toll. So that's the one distinction that I would make. But I think those are the reasons why we end up in that category, is because of all the other risk factors that tend to go along with the heart disease.
And I would add that, it was said in my long bio that I teach health policy too, and that's a big factor as well. Things like access to care, things like insurance coverage, ability to find a physician or a medical provider, ability to afford your medications, things like that can lead to you being more likely to be able to access the healthcare system and to take your medicines on time. And a big thing that I'd love to mention is COVID-19 actually increases your risk of heart disease. Even having had a mild case of COVID-19 can increase your risk of cardiovascular disease. So, and as we know, COVID-19 has disproportionately affected the African-American community. And so even another reason why it can then increase the rates of heart disease that we're going to see even going forward into the future.
Great question. And I'm glad you mentioned the COVID-19. And I'm just hoping that someone can help me to understand, how is it that you're finding COVID-19 impacting the heart and or cardiovascular disease?
I think there's several guidelines out, some put forth, or consensus statements put forth by the AHA, as well as the European Society of Cardiology. And for the most part, they highlight several things. One is shortness of breath. And in most patients, honestly, that tends to go away within 3 to 6 months. You have some patients who will experience more palpitations, feeling their heart racing. And that tends, again, to lead or to go away within 3 to 6 months. You have a very small group of patients who will have the virus and then develop what we call a myocarditis. And so that's an actual sort of inflammation of the heart tissue that occurs as a result of the infection. And some of those patients recover and some of them don't, right? And we don't really have numbers enough yet to say what percentage actually will do okay and what percentage tends to continue to have some of these issues. And so when I tend to tell individuals when they're asking, well, I had COVID, how do I know if I have something going on? If you're short of breath and that shortness of breath is lasting for more than a month or so, you need to check in with your primary care. And if they're concerned, they'll send you over. If you're having the palpitations, you should also check in with your primary care, and they should consider sending you over. If you're starting to notice things like difficulty lying flat when trying to sleep at night because of shortness of breath, swelling in the legs, all signs of heart failure, then that's another thing that you would want to touch base with your primary care physician, and they will forward you on if they are concerned as well. And that's sort of the classic triad of things that we oftentimes will see in patients, longer than sort of the month that you typically would expect people to have symptoms and then recover.
Okay,
I would
thank you
like to
so much.
also add as well from a perspective here, is that again, with COVID and pregnancy also does put stress on your body, your vessels, and with COVID-19 and that effect on your body, it can make you, even worse. So, when we were first dealing with COVID and was first coming out, we were seeing a lot of moms that were having some of that stress on their heart and that worsening, even their pregnancy. So we were seeing a little bit of an uptick. I mean, again, we don't have the numbers to say exactly, what was happening at that time, but we were seeing an uptick of women who were pregnant getting COVID-19, but getting very sick and then causing preterm labor complications with babies too. So it's really important to make sure you're getting your vaccines.
Thank you. Well, I now see a member of Xi Omega chapter, Dr. Lavdina Orr, who has joined us, and I'm going to pass the baton to her as she will continue to moderate this panel on. So Dr. Orr, thank you so much for joining us. And I'm just going to give it and leave it in your capable hands.
Well, thank you, Nicole Jackson Williams, our first Vice President, and thank you for the opportunity to participate in this evening's panel, which is so very important to all of us and to all of future generations to come. So I think I should start with, I heard Katrina talking about hypertension and how it affects pregnancy. So I guess a very good question a lot of patients always have is, I had hypertension during pregnancy. Is it going to go away? So what's our message?
So does it go away in pregnancy? Most of the time it does not, unless we are doing something to, mitigate that, i.e. putting you on medications. We really don't put people on bed rest anymore, but trying to decrease those factors that are creating, even more stress in your body, making sure that you're tighter controlled if you're a chronic hypertensive and making sure that you're taking your medications well. Does it, again, come back after pregnancy? Again, we don't know whether or not it's going to come back after pregnancy. That's something that we still need to do a lot of research on. And then we talked earlier about how it can develop into chronic hypertension as well. So, the jury's still out. We don't know what's going to happen, but that's why we monitor you closely and to see if we need to pass you on or pass the baton over to family practice.
Yes, that's a good answer. But, we have all these medical terms like hypertension, preeclampsia. Can you tell us, break it down? What is preeclampsia? What does that mean?
Sure. So preeclampsia is when someone who normally has normal blood pressures coming into pregnancy, and then at around 20 weeks or so, they will develop or start developing hypertensive episodes. So they may come into the office and have a 139 over 87. And then the next time they come, it's a little bit higher. And so you may see a trend, you may not see a trend, but it's really when someone has two of these blood pressures on two different occasions, at least 4 hours apart, then that's what gives us gestational hypertension. Preeclampsia, again, is when you have a change in your in your labs showing that there's organ damage.
So what do we do about that?
So a lot of times we can see how your blood pressures are doing. We may monitor and just see over the course of time whether or not, they stay stable where they are. We may start you on medication to see if that's helpful. Sometimes if it gets, so bad where you're having hypertensive, where it's in the severe range, you might be seeing us in the hospital to see whether or not we can mitigate that with IV medication. And then depending on how many weeks you are, you may be either delivering early, or we may just keep an eye on you with, some medications that will keep your blood pressure stable throughout the pregnancy, at least till we can get you to term pregnancy, which is 37 weeks, and then deliver after that.
Thank you. I think the next questions are for either Dr. Findley or Dr. Anderson, So if this question's already been asked, then let me know. Everyone wants to know why is there still a steady increase in the rate of heart disease in our community, despite all we're doing, the advanced knowledge, the medications, medical technology, emphasis on healthy lifestyle? Is there a reason why we still are seeing a steady increase, or are we seeing a steady increase?
So yeah, we're definitely seeing, actually, one of the points you made earlier was that we're seeing a decline in the numbers, but we definitely tend to have higher incidence of the heart disease relative to other groups. It doesn't matter what group you want to bring up. And so just trying to hone in on some of the issues, some of the policy issues were brought up, some of the medical issues, some of the lifestyle and risk factor social issues were brought up, as well as ways to help mitigate some of that risk and reduce the numbers. But some of what we're doing, conversations like this, they're actually working, right? Because we have seen, at least if you look over the past 10 years, a nice slow decline or reduction in all groups, but and as well as in the African American population.
And I would add to that, we were saying that heart disease is a progressive disease over many, many years. We often don't start thinking about heart health or heart disease until we're in our 40s, 50s, 60s, when unfortunately some damage might already be done. So we need to really focus even on our teens, our kids, keeping them active and really incorporating family health as a regular practice, right? Exercising together, always having, healthy foods available, not just when such and such is on a diet, having this being a regular part of our communities and a regular part of our gatherings, because we know that we face several disparities. We call them social determinants of health. Some might call them even political determinants of health, that can be the result of policies that have inflicted structural disparities on the communities in which we live. Things like poverty, violence, inadequate shelter, inadequate food access, right? Food deserts, the inability to get fresh fruits in certain communities. I mean, there's so many things, right? The list can go on and on. And so many times we look at it as like, how come I can't, we can't get on top of this heart disease thing, but we really have to look at the structures in which our communities live that are causing a lot of these disparities and these chronic diseases to persist. So it's both things, right? Definitely, we need to take some onus, exercise, eat right, the whole thing, take your meds, everything. But at the same time, let's look at the structures in which we're living. How can we change that type of access so that we're not facing these disparities?
That's an excellent answer to the question. So are we seeing conditions in in children and adolescents now that lead to chronic heart disease or lead to hypertension? What should we be doing with our children and our adolescents?
Definitely. I'll jump in on that. As a family doctor, I see children, I see pregnant women too, and see adults. And we see a lot more cases of diabetes in our young people, elevated weight and obesity earlier on in our young people, to show that those type of things do lead towards more heart disease as they get older. So I would say even focusing, it's always a delicate balance, right? Because we want to build up the self-esteem of our young people. We want to let them know that they can be anything, do anything, but at the same time, we want to let them know how important it is that they take care of their health from a young age. And the way we do that, we model that behavior, right? If you're not taking care of your health, but you're telling, hey, go out and play, but you're not going out with them, to run around too, what kind of message are we sending to our kids? I'm talking to everybody here, me included, that, modeling that type of healthy exercise, healthy behavior for our family members makes it a group activity, makes it not a punishment to eat the fruit, makes it a fun thing, right? That everybody's involved in, and that we know that can lead to healthier outcomes.
Thank you. I've been asked to ask both of you to speak to diabetes and how it plays as a risk factor. Has that been discussed already? There's someone wanting to hear a little more about that.
Okay. So diabetes at a very sort of at a basic level, cellular level, the increased sugars over time sort of wreak havoc on the inner lining of the blood vessel. And the inner lining of the blood vessel is actually very important in helping to control how the blood vessel responds, how blood pressure is sort of determined. We call it vascular resistance or vascular tone. And so as you start, the increased sugar levels tend to wear down these cells and alter some of the signaling pathways. That's a whole lot of sort of biological talk to basically say these cells now start to interact with their environment a little differently than they have before. And what that tends to do is some cells die off. The cells generally tend to have a nice network, but over time with diabetes, that network increases or opens up. So now you have these gaps between the cells, which enables certain blood cells to get into the blood vessel. So beyond that innermost layer into the second layer, which is called the media. And then you start to have problems. So you'll get burying of the cholesterol deposits, the macrophages, the foam cells. These are all different types of cells and fat that gets deposited in the blood vessel wall. And over time, that then leads to successive narrowing of the blood vessel, which leads to reduced blood flow, right? That demand mismatch, and then you start to develop symptoms. And so it's a very slow, insidious process that occurs over the course of years, all because of that increased sugar level and how those cells interact with that increased sugar level. And then you can see sort of the direct relationship between what's happening at a cellular level all the way to a patient who then gets a heart attack 20, 30 years later.
Wow, I mean, that's important. And the medication adherence or being compliant with taking meds, even though you're not having the symptoms now, is so important to prevent further damage. I think
Correct.
that's the message that we're hearing. I'd like to go back to Dr. Anderson and hear your thoughts as well from the family practice perspective. We've heard our premier cardiologist tell us his perspective, but I'd like to hear yours too.
Yes, it's very hard to follow the premier cardiologist, but I will add that definitely there's a cellular level of cellular damage that diabetes can cause, especially within the blood vessel, right? And that's how, like, as it was described, that's how the cholesterol can build up. That's how those blockages can form within your blood vessels because of those like little micro tears on the inside of the blood vessels, as Dr. Finley explained. Another thing I see a lot with diabetics is the neurologic damage that it causes to their feet, to their senses, makes them feel more sickly, unable to, walk, unable to run or feel energy to move around. And that is going to affect their ability to be active and subsequently affect, lead to higher rates of heart disease. We even consider diabetes a cardiovascular equivalent, right? It's like you've had a heart attack already, right? Even if you haven't had a heart attack, it's counted as high as the risk factor of someone who had a heart attack just by having diabetes alone. Because we know that many times when people are diagnosed with diabetes, they already had it up to 10 years before, and they didn't know that they had it, right? So it's already created all that damage and all of that, the blood vessel damage that the premier cardiologist let us know about. And it's very true what he said. These things all work together. Sometimes it's hard to tease out, like, was it the blood pressure? Was it the heart? Was it the high blood pressure? Was it the sedentary lifestyle? It was kind of a salad of it all, right? That's why we need to prevent those things before they happen. Or, don't feel bad if you've already been diagnosed with some of these things. It's not too late to try to turn it around. Even losing 5 to 10% of your body weight can decrease your risk of having a bad outcome from your heart disease, right? So for those listeners who are listening and they're thinking about their moms or their grandmothers or even themselves, it's not too late, right? Small steps, small changes. Tomorrow is a new day and you can turn around your diet, you can turn around your activity, and you can make a commitment to living a healthier lifestyle for yourself and for your children. Many times my patients will say to me, "Oh, Dr. Anderson, I promise I'm going to do this for next time. I'm like, don't promise me, promise your daughter, right? Promise your mom, promise the people who are depending on you, right? Those are the people who are going to miss you when you're gone. I mean, I'm going to miss you, of course, right? But there are real people that are depending on you, make those changes either for yourself or if not for yourself, for them.
Well, Dr. Anderson, that's such great information. I know your phone lines are going to blow up tomorrow because everybody's gonna be trying to get an appointment with you, our fascinating family medicine physician on this phone. However, I know that I have to turn it over to Kashana now because there's some questions in the chat. So thank you both for your very insightful information.
Good evening, everyone. Thank you so much, Dr. Orr, for turning it over to me. I do have 2 questions, and we will take them one and then the other. The first question is for Ms. Richardson, and the question states, as a woman with no previous heart or blood pressure issues, she was diagnosed with postpartum preeclampsia, leading to 3 postpartum hospitalizations. Now, here it is 8 months later, she is still on blood pressure medicine. Have you seen an instance like this eventually reverse and have stabilization in your blood pressure so far postpartum, or is it likely to be a long-term issue?
Yeah, so we touched on that a little bit earlier. A lot of times we will see postpartum, immediate postpartum, where you may not have even had hypertension throughout your whole pregnancy. And then after you deliver, we start seeing some irregularities in your heart rate and blood pressure issues, which cause you then to be admitted to the hospital for medication treatment. Again, it's difficult to say whether or not that it will become a chronic condition for you, or anyone who has that. But in my instance, I usually see people up until that 6th week, and then I send them on to their primary care. I would say about, in my readings over the years, about 40% of those people that have severe hypertension in pregnancy will go on to develop chronic hypertension within 10 years of that delivery. So it can stay stable sometimes, and it can become, more of an issue where it's more long-term chronic. I don't know if either Dr. Finley or Dr. Anderson has, from their perspective, what they're seeing on the other end. That would be a good question for them.
Does either one of you want to chime in?
I'm okay, Dr.
Yeah.
Anderson.
Yeah. No, I mean, I think you answered the question perfectly. I don't have anything to add. I think always, remembering that all these things work together, and that, they are things that you can turn around early.
Thank you. Next question is actually for you, Dr. Anderson. With your policy background, how successful have you or your colleagues been in pushing or pursuing poverty, violence, etc., as a public health issue? Or have you even tried?
Oh, definitely always trying. I think it's a big problem. And, we see that there's places in the US, even especially where heart disease is the highest in women, for example, in the Southeast, the southern states, it's where the rates of heart disease are the highest, where you see no green space, you see, communities without sidewalks, right? How are you going to tell people go outside and walk if they're afraid of being outside, right? It's dangerous for them to be outside. Gun violence, all of these things work together to perpetuate these rates of heart disease in our community. So I think really, approaching it from a policy perspective, really being able to tie those rates of heart disease to those structural factors. In the US, there's still a very strong adherence to trying to find a genetic difference, like a genetic reason, like, oh, Black people have this because they're Black, right? Like really, like trying to figure out, like, well, we must have worse hearts. No, we have the same hearts as everybody else. What we have is communities that don't allow us to exercise, for example, parks, no green space, access to care. I mean, all of these things, really make heart disease a public health issue. And like I said earlier in the webinar, we have our individual responsibility 100%. I mean, I'm not absolving any of us from going out and doing the work, but I do think that we do have to be active with our pushing our political leaders, pushing our health leaders, to look at how these kind of structural barriers can perpetuate these health disparities that we see.
Thank you. There was a question for Dr. Finley in the chat, but he answered it already. So I will leave that one there, but there are two questions. I think one is a little easier to answer, so we'll go with that one first. And this is for any of the panelists. Are there any concerns or risks with having a low resting heart rate over time?
So I put a quick answer to that. If you don't have any symptoms, in general, we talk about lightheadedness, dizziness, feeling like you're going to pass out, passing out, fatigue, and sometimes shortness of breath. If you don't have any of those symptoms, then a low resting heart rate is generally a sign of a healthy heart. If you do have those symptoms, though, that may be a scenario where you'd want to have that evaluated, just to be sure there's nothing else going on.
Right. And I would say the same with a low blood pressure too. Many times patients will say, oh, I have low blood pressure. Is that a problem? If you have no symptoms and that's, just kind of chronically where you are, then that's not a problem specifically. Now, if you have a higher blood pressure normally and suddenly it becomes low, then we need to look into that, right? But if it's just kind of where you land, that's okay if there's no symptoms or it's not a abrupt change.
All right, and our final question. Final question. Is sustained and increasing C-reactive protein a concern for heart issues if no other indicators are surfacing in blood work and other testing? Or should anti-inflammatory foods or practices just be implemented to reduce inflammation in the body? And that's for anyone.
I'm going to give that to Dr. Finley.
So CRP, I'll be honest with you, it's used as a screening tool, and there is some data out there that suggests higher CRPs do correlate with higher incidence of inflammatory disease, right? And so the hallmark, or sort of the foundation of heart disease, is inflammation, as we kind of discussed a little bit earlier, in terms of cells getting into the layers of the heart and layers of the vessels and wreaking havoc. But if you have no other indicators, you don't have a family history of heart disease, none of the other things are elevated, it could be a sign of just general overall higher inflammation levels in the body. And one of the things I absolutely and positively do recommend is exactly what you said, which is anti-inflammation diet. I think I'll take a step back. One of the things I wanted to leave today with, because there's a lot of this has been doom and gloom, these are the bad things, these are the things that you need to do to improve, but we can actually grab the bull by the horns. And there's two things that I recommend patients always do. First is go get CPR training. All right, I had a case, and this guy is still living today. This was 2 weeks ago, I was on call. The gentleman came in from church, passed out. So he was at church, went down. The church did not have an AED. His daughter, who happened to be a PICU, so a pediatric intensive care unit nurse, started chest compressions. So I knew he got good chest compressions. Somebody was there to at least administer, but that person can't do it alone. And then they were able to get the patient there. And we ended up, I saw him and I recognized that person needed surgery emergently. So I transferred him out to Maryland. I did what I had to do and then stabilize and put some things in him so that he would sustain himself, and then sent him out. But that's a scenario where his daughter literally saved his life. And that's because she knew how to do CPR. That's number one. Number two is sort of taking the bull by the horns. There's two diets I recommend. One is the anti-inflammation diet. And you can look up, there's a great book called The Complete Idiot's Guide to Anti-Inflammation Diet. Just Google it or look it up on Amazon. The second is a plant-based whole food diet. That is the one diet, and there's plenty of data to support this, that has actually been shown to reverse, is what I meant to say, cardiovascular disease and reverse diabetes. And so if you're plagued with any of that, or you're concerned about getting to that point, that is something that you can implement that potentially will reverse the likelihood of things going on. So if you had diabetes, their A1Cs come straight down. over time, or if we had patients where I couldn't put any stents in, the anatomy wasn't good enough, and we put them on this diet and they adhere to it, and they come back and all the symptoms are gone. And people have gone back in and taken a look at their arteries, and their arteries actually look improved. So there are things that we can do. This is not all doom and gloom, and that's the only thing I wanted to make sure I imparted today.
Yeah, and I'd love to add to that, those kind of dietary modifications are definitely very important. And a big thing that we have not mentioned is if you're smoking or if you smoke tobacco products, you have to stop. That is a large risk factor for heart disease, cardiovascular damage, vascular damage, a whole bunch of damage can come from smoking cigarettes. And that's actually a really big intervention that people can make that can really change outcomes. So I want to add that to the list of maybe not doom and gloom, but opportunities for a new beginning tomorrow when we can modify those risk factors and really do better for our communities and for those who are to come.
Thank you. And we did get one final question. I think it's pretty much a kind of yes or no. If you had gestational hypertension in one pregnancy and it resolved, should you expect it again in any subsequent pregnancies?
So that's a really great question. That's $1 million question, actually. Not that it will happen, but the likelihood of it happening is increased in your next pregnancy. So definitely that's something that you need to, if you have a different provider for your next pregnancy, definitely need to say, hey, I had hypertensive disorder in my last pregnancy. So that will really hone them in on just really getting in and getting some of those labs done early, getting a lot of the assessment and information from your last delivery. So we can hopefully mitigate having that at least be more severe for the next pregnancy.
Thank you. That concludes my questions from the audience in the chat. I will now, I'm not sure if we will have Nicole or Raven, but I'm pretty sure it's going to be Raven L. Hill, the president of Xi Omega chapter, to bring us some closing remarks. So thank you all for being here.
Thank you, Kashana, and thank you so much to our panelists, Dr. Anderson, Dr. Finley, Richardson, for sharing your expertise with us this evening and continuing our conversations as part of this Women's Health Week of activities. I mean, when we talk about achieving healthier futures together, it goes straight to the heart. So thank you so much for the information on diet, on nutrition, for even you may be considering pregnancy, just things you need to consider. I just want to thank you on behalf of the members of our chapter. And before we close it out, I'm going to bring Nicole back to share with you information about our final activity of the week.
Thank you so much, President Raven. Thank you. I want to say thank you again to all of our panelists, Ms. Katrina Richardson, Dr. Anderson, Dr. Finley, and Ms. Kashana Morrison. Thank you all so much. I believe, and also Dr. Orr, everyone created a rich conversation that we needed to have. And so our last activity for this week, please join us tomorrow, Friday, for our midday meditation. It will be given to you by one of Xi Omega's 50-year members, Ms. Crystal Kirkendall, and she's going to leave you with a peaceful yet a powerful meditation. So please join us. You can go to the Xi Omega Facebook page, also our Instagram page, to get more information and to register. And thank you all again. Have a wonderful evening, and we hope to see you all tomorrow at 12 noon. Good night, everyone.
Thank you.